All right, good morning, everybody. This is Alex Dolan with IBI, and thank you for making the time to hop on our webinar. This is part of a series of sessions that came out of our IBI annual forum that was a few weeks ago in March, and we are really lucky that Tanya Barham is here to present her session, which was a very popular session at the forum today, and I am with IBI, and again, my name is Alex Dolan. I wanted to just quickly get started by thanking the folks that made this possible, which are a lot of our sponsors who funded the forum and this series of webinars, including AbbVie, the Hartford, Shape Up, Anthem Blue Cross, Cigna, and Sedgwick. And I'm happy to introduce Tanya Barham. We are going to turn things over to Tanya. This is going to be an interactive session. If you have questions, feel free to type them in the chat box of your webinar control panel. Otherwise, we'll also take questions at the end of the session. So with that being said, I'm going to turn this over to Tanya, and she can get started.
Thanks, everyone. Let me just identify which screen I'm showing. There we go. So thanks, Alex, and thanks, everyone at IBI, for giving me the opportunity to present again. As mentioned, my name is Tanya Barham, and I am coming to you today from Multnomah County, which is the second largest municipality in the state of Oregon. We're the county that houses the city of Portland, covering a very large slice of land, as well as employing approximately 4,500 full-time equivalents throughout the course of the year. Additionally, we insure, as many public employers do, we have a rich benefits plan. We have 11 collective bargaining units that represent about 80% of our workforce. And those unions represent those employees, and we also insure the spouses and dependents as well as domestic partners of our employees. So we have additionally about 800 to 900 retirees, so a total of about 13,000 lives on our plans, health plans. We have a self-insured PPO plan that's administered by a local health plan, and we have an HMO through Kaiser. So we just give you that, and about 75% or maybe 70%, two-thirds of our insureds are on the HMO. So I give you that background just to sort of give people a flavor. We also have a self-insured workers' compensation program and other disability and leave programs that we self-administer. So I give you that to give you just a flavor of this public employment environment. And there might be many of you on the call, and at this point I'd like to welcome folks to send a chat and let me know, what kind of employers you represent, but you're probably wanting to know, well, how is what you're about to talk about relevant to my employment environment? And I would say that what I'm about to talk about is relevant to any employment environment, and part of the reason I'm able to say that too is that in addition, prior to coming to the county, I had more than almost a decade worth of experience running similar wellness programs, the same process that we're using at the county in other employment environments. And I think that it's a process, though, that is particularly well suited to difficult environments where there's not a lot of latitude around money. I'll talk a little bit more about that later, but I will say that before I came to the county, like many employers, had a wellness program. So it did have an existing wellness program. I'll just really quickly show everybody here the website. This is our current campaign that's ongoing, but we also, have all your typical stuff here. So 2 on-site fitness centers, which is pretty great. We have fitness classes, so a whole suite of fitness classes that we offer at about 5 different locations, so people can go onto our Google calendars and take a look at all the classes. They're open to retirees, spouses, and dependents. Pretty nice. We have breast pump loan programs, nursing mother spaces, weight management subsidies, gym discounts, personal trainer offers, really just a mini grant program, lots of great offerings. But after looking at 4 years of data prior to my joining the county, I could see that we'd never really had the most participation we'd ever had across the board in any of our programs was 5% of our employee population. So, even less if you looked at our total member population. And worse than that, typically the most frequently used services, which were the fitness classes and fitness centers, engaged less than 1%, in some cases less than 0.5% historically, and many of our programs really only engaged a handful of people every year. In the meantime, like many employers, we were seeing the same thing happening over and over and over again, which was, hey, our healthcare costs are going up 10% per year or 4 or 5% per year. We also have an older workforce. Because we have a highly unionized environment, the average age of our workforce is 47 years old. As you know, when you have cutbacks, which most municipalities had due to lower tax revenues in the past decade, it means that you bump people who have less seniority. And so we ended up having an older workforce, which also means, greater healthcare costs. So of course, there's wellness, and everyone says, well, wellness should be a solution, but we'd had a program. We'd had all the good programs. They weren't doing anything really, though. They weren't reaching enough of individuals, and it's not to say that they weren't making a difference in the lives of the people who were engaging. Certainly they were. There's no question that the people who used the programs found them to be valuable. The problem was not enough people were using the programs, and anyway, the programs were sort of squirreled away and not really part of the culture. So about 1.5 years ago, the county decided that they wanted to hire a cultural change agent to try and create a culture of health at the county and move to what best practices said is a more durable way to create change in people's behavior. That is to surround them with an envelope of thoughts, cultural norms, behaviors that engage them in a process of self-discovery around health and community-supported health in our work community, that is, that are likely to result in a better trend, better health outcomes for those individuals, better outcomes for our work community in terms of productivity, reduced absenteeism, et cetera. That's a long process, that money-saving looking process, because when we look at the cost of healthcare, by the time someone's being treated for, let's say, an advanced form of diabetes, poor A1C control, high blood pressure, cardiac illnesses, it's not like getting run over by a wagon wheel or contracting tuberculosis. This is not an event that has a quick origin. Typically there are genetic risk factors involved for that individual. And then, of course, the way that their behavior and environment interacts with those genetic risk factors puts them at increased or decreased risk for developing a full-blown disease. Once they are diagnosed with a condition, they may go on over long periods of time to either have very good control over, let's say, their blood sugar or their blood pressure, or they might have more sporadic control, not adhering to their medications or behavioral and lifestyle changes that would be helpful. So it's a complicated process. It's a long-term process. And when we talk about wellness, we hear so much hype about it. And everyone keeps talking about 3-to-1 return on investment. But the truth is, what is wellness? What is it that gets 3-to-1 return on investment? When we talk about wellness, what I've found is programs can be talking about anything from a massage therapist coming once a week to a full-blown program with health risk assessments, biometric screenings, hundreds of dollars of incentives, fitness centers, fitness classes. It runs the gamut. So what am I talking about? First, I just want to sort of set the stage with what am I talking about when I talk about wellness? When we talk about the kinds of programs that save money, the kinds of programs that you read about all the time in the press, these are not we did one walking campaign and wellness is done, or we offered Weight Watchers at work, or some little amalgam of programs. These are typically comprehensive population health engagement strategies over an entire workforce that don't just change 1 or 2 people's lives, they really change that whole envelope. And this is very important. If we look at this bell curve and we say, this is a normative curve or this is a bell curve diagramming a population, an entire population of people, and the likelihood that they might develop a disease, a lifestyle or a chronic disease. Let's say that down here is 0 risks and up here is 5 risks. And right here is, let's say, 4 risks. And this is the point at which predictive models tell us people are likely to tip into that category of disease state. So here we are, we're at 4. Most wellness programs are so focused on the programmatic piece. They really hop right into this piece of let's just do a thing. Let's do a challenge. Let's do a campaign. Let's buy a web portal. Let's do a health risk assessment. Let's do a biometric screening. And in focusing so much on action, what they do is there tends to be sort of a picking off of the herd, which is not entirely bad. So you've got your fitness classes, your fitness centers, those types of programs. Those are typically going to attract your already healthy individuals, the ones who don't really require very much change. And even your biometric screening and HRA, and we're aware of that when we run our programs. You know, if you're doing it voluntarily, which we really more or less have to, you're going to get these folks who are already fairly healthy. Now, your disease management, your case management, your intensive outbound coaching with incentives, those are going to probably get folks who are already identified by your health plan as someone in need of some chronic condition management. So they've already been picked up, in all likelihood, by an algorithm that your health plan or your third-party administrator has in place on disease and case management. But sort of the irony of it all is you rarely get these people in the middle who might look otherwise healthy. They might not be triggering any alarm bells. They might not be going to the doctor, but they're also not super likely to participate in your wellness programs. However, one thing we know with certainty in the scientific community is that risks tend to increase over time. So now the folks that were really at risk, the high-risk folks, it's great if we can move them down in terms of their level of risk. That is fantastic. But they were already in the high-risk category anyway, so we're not really changing our population curve all that much if we've been focusing on them at 4 risks and now they've moved into 5. They still were in that category that we'd identified. The low-risk folks, sure, we might stop them from moving from 0 risks to 1 risk or 1 risk to 2, but they were still going to be in the low-risk category. But the missed opportunity here are those folks in the middle who never engage in our programs and now were never identified by any of our specific programs, never participated, and have now moved into that category of high risk. So in addition to programs, you have to have programs. You also have to have a strategy for encompassing an entire population, whether they sign into your portal, whether they participate in Weight Watchers, whether they do a health risk assessment or not. You need to have a means by which they are impacted and they are hearing the message and it is changing their thinking and behavior, whether they engage in a specific program or not. Obviously, there's huge benefit here. If we have someone here who loses 30 pounds, if we have someone here who reverses their pre-diabetes diagnosis, I'm not trying to say that that doesn't matter. It matters very much to that person, their families, and the workplace. But the thing that we really need and what science shows us, and I think is actually very counterintuitive for most folks, it doesn't feel like this should be true, but it is true, that small, sometimes even imperceptible changes that we might not be able to see. You can certainly see when someone's lost 30 pounds, and I, of course, will show you some case studies of things like that today, too. Those are impressive, and those leave a mark. But truly, if we want that big change, if we want that population change, and if we want those savings and that overall improvement, we might not have everybody running a marathon, and it might not be completely obvious on the outside. Not everyone's going to have lost an amount of weight, for example, where you could necessarily tell simply by looking at our workforce. They're not all going to be running marathons. But small actions by lots of people add up to big change. And when you think about, like, diabetes, for example, a weight loss of only 5% of total body mass can have an enormous and a huge impact, or no weight loss at all for that individual, but increased aerobic activity that will help them get that blood glucose out of their bloodstream and into their muscles. And research tells us that's an incredibly effective way for someone to manage their blood sugar, but we might never see that on the outside. We might never see that in our BMI numbers, but we might see it in our physical activity numbers, or we might see it in our A1C blood sugar control. So we want to think about how to change people's minds so that lots of people in our population are making lots of small changes in ways that are personal to their lives across our whole population. But how do you do that as an employer? What is the means by which you do that population change? Because we all know about the programs. Any of us can read about Safeway or PepsiCo and just say, well, they did a walking campaign, so I'm going to do a walking campaign. Well, they did an HRA, so I'm going to do an HRA. We can sort of get the laundry list. But one thing that I like to say is, you can hire Madonna's personal trainer. You can buy all of Madonna's clothes, but it doesn't make you Madonna. So, just getting the programs in place and just trying to mimic the behaviors of another organization isn't truly getting to what will drive an effective wellness program. But you know what? There is a benchmark that can measure how Madonna-like you are. So if we were to look at, Madonna's behavior set and compare ourselves against it in that benchmark, there's something similar for health promotion, and it's called the HERO benchmark. So the HERO is the Health Enhancement Research Organization. It's a nonprofit organization that's been around, excuse me, since the 90s. It's members of the HERO have worked on employee health engagement for a long time and have been looking at what types of behaviors, organizational behaviors, really drive and impact how comprehensive a program is, and in recent years, how likely it is to actually impact their healthcare cost trend. So what they're saying is, other than just the programs, though programs are part of it, so part of the benchmark is what clothes are Madonna wearing, what perfume is Madonna wearing, and who is her trainer. But out of the 60 assessment questions on the HERO benchmark, only a fraction of them are about programs. So what are the other questions about? There are sort of 6 main categories of questions that we want to think about when we're thinking about, driving that health engagement. The first is strategic planning, and I would say strategic and tactical planning. So this is creating a data baseline. It's looking at your baseline numbers. It's not just, ready, shoot, aim, sure, all we need to do is X. It's different. Our approach has to be different for every population, and we have to market to our audience. So strategic planning says we're going to gather a lot of difficult data. So in the case of the county, we'll look at some of that data in a minute. I won't spend a lot of time on it now. From there, we're going to create a strategy over the next 3 years, and really, we're not going to play slops when we play pool. We're going to call our shots. So we're going to say, look, we spend $3 million a year on cardiac illnesses and another $3 million on diabetes, genitourinary, and other issues that we know have a close relationship with metabolic syndrome and heart issues. So if we're spending $6 million a year, we not only want to try to reverse the average cost of a diabetes claim by helping people catch it earlier, but we'd like to make it so that fewer and fewer people progress to that level of illness. And we want to think of a way to do it that's all-encompassing and fun and that everyone in our very diverse population can relate to. So strategic planning are what some of the questions are about. Leadership engagement are the others. And this is not trotting out your CEO for every event. In general, for leadership engagement, and leaders don't just come from the top, they come from throughout the organization. This is about, yes, having your leaders support the time necessary that it takes to build a grassroots coalition and that it takes to build culture change, that they understand that this will take a long time, that they're funding it not just in terms of money, which is great, but like in the case of the county, we didn't have a lot of money to throw around in comparison to some private sector employers. So the leadership engagement is really getting the commitment from leaders that they'll support voluntary participation in the programs. In addition, they'll support wellness teams and other members actually creating the grassroots coalition to spread the word within the organization. And that this is, these are things that you can do, like holding meetings with your leaders and asking them to participate and asking them to support, but also asking them to identify people that they think would be good champions and making sure that they support those folks' involvement. The HERO also says there needs to be program-level management. So the average employer, according to World at Work, has 18 different wellness vendors, 13 to 18. That's a lot. And in general, most of these programs are duplicative in many ways. They might duplicate each other's work, and they're not integrated. This gets all the harder if you're an employer with, let's say you're in the middle market, you're about the size of the county, so you have anywhere from 400 to 10,000, 12,000 employees. Under, about 50,000 employees, it can be very difficult to integrate, but finding ways to document processes, create a vendor summit, and to really familiarize people in the organization and to connect your programs in a way that seems intuitive to the user so they're not having to deal with 13, 18 different programs all the time. It really seems like a single, unified, coordinated plan. So there's a lot of coordination involved in that piece. The other part is, of course, what programs you offer. This is where most employers do a pretty good job, is on program and program level management. They spend a lot of time buying pedometer challenges, buying Fitbits, buying portals, buying HRAs, buying gym memberships. And so this isn't one where most employers do a poor job. However, engagement methods is one area that's a big differentiator between the types of programs that save money and the ones that don't. And this is where employers tend to do a very poor job. They might do a couple flyers, some emails, they have the CEO show up for a thing or two, but there's not a lot of creativity in the types of communication tactics they use. Additionally, they rely way too heavily on one or two people in their organization, or they rely on their health plan to create slick brochures or their vendors. Unfortunately, that's not real engagement. The employee population is not fooled by a skinny woman eating carrots on one of your health plan's flyers. They know who butters their bread, and that is not their employer, and they don't need to pay attention to that, and so they won't. Engagement methods really, there was a great article by Towers Watson, and I'll say it slowly so that everyone can write it down. It was called Wellness Participation, Boosting Participation Without Breaking the Bank, is what I believe it was called. It was a Towers-Watson white paper from, I think, 2009. And they did some mathematical modeling around engagement methods based on data that they collected. And what they found was that the programs with the highest engagement used a minimum of 9 different communication tactics during every campaign that they ran. And that engagement methods were more valuable than cash when it came to garnering participation. So a couple different engagement methods might be as valuable as offering $190 to take an HRA in your organization. So this is one area where most employers, especially smaller employers, do very poorly, and it's where the hero, I think, can provide some real guidance. And then measurement and evaluation is another area that employers do very poorly. They tend to want to just get straight to the point. They might not have access to the types of measurements that they need, but we'll talk a little bit too about, using the hero as a benchmark as one place to start, but also trying to think creatively about how you can measure and what you can measure in your workplace. So now let's talk about the county. We did the HERO assessment as an employer in 2012 and scored 43 out of 200 possible points. So just so you know, very few employers score 200 points. There's diminishing returns for trying to do everything right. But what the HERO has said is that employers who are bending the trend and seem to be impacting their healthcare costs are scoring about 129 points out of 200. So as you can see, we had a way to go. But we weren't alone. When there's a survey called the National Worksite Survey, and they found that when they surveyed employers about how comprehensive their strategies and standard operating procedures were around their wellness programs, that fewer than 7% of employers had comprehensive programs. So in that way, the county was not different than most employers. And this stat is particularly true for employers that have less than 750 employees. So what was the real difference? It's this social aspect. It's the coordination aspect. It's the engagement methods. What the HERO was finding is that employers that had high leadership support, high engagement methods, really good coordination, a very grassroots coalition, and all that cultural change piece were the ones who were really getting engagement. And I think when a lot of people think about that, they think, oh my gosh, that just sounds like so much work. I know. Let's get a social networking platform where we can actually, go out and say to everybody, let's gamify, let's all get badges and points for participating. And I do think that it has become, just because we call a tool social does not mean that it is truly social. And I think this distinction is important. We've labeled social media social, but it doesn't use the same pathways as true face-to-face interaction. And I think it is very tempting to want organizationally the magic bullet, to want a product that will do the hard work that we don't have the time or ability to do. But I'm here to tell you today that this is, just like the fat jiggling band or smoking were considered a valid way to make yourself slender. I believe that we're going to see people starting to get very tired of social and gamification, and that trend will also move on, because that's what it is a trend. But what never changes is that human beings have been wired to be truly social neurologically. So there's been plenty of studies that show that we have something called mirror neurons. We have a way of relating to one another where we can catch each other's emotions. And all of this I'll start talking about Multnomah's program specifically in a moment, but it's very important that I set this up for you so that you understand why we did things the way we did. So human beings have these mirror neurons. When I see someone smile, not only do I smile, but I feel the emotion that they are feeling in my body. My brain has the ability to recognize this little girl's smile and to trigger that emotion in me when I see her face, when I interact with her. The flip side is also true. Negative emotions can be contagious. And what we found is that as we pass those things socially, I mean, a social network doesn't, we've tried to use emoticons, but it's not quite the same thing. Our brains are wired to respond to human faces, and that's long been hard-coded. But how does that work in our networks? So a really cool thing happened a few years ago. There's a large epidemiological study called the Framingham Heart Study, and this study is how we know most of what we know about heart disease risk in the United States. We're now on the third generation of that study, so the grandchildren of the original participants are now participating. And it was a small town in Framingham, Massachusetts, where they asked people a lot of questions and then followed them over decades to see who developed heart disease and who didn't, heart disease being the #1 killer in America. So in order to be able to track these folks over decades, they had to ask them things like, who's your spouse? Who are your kids? Who are your friends? Who's your boss? Who are your coworkers? Who are your neighbors? So that they could track this person down if they moved, divorced, whatever. But a couple of smart Harvard researchers, Nicholas Christakis and James Fowler, once computing technology had caught up, said, hey, wait a minute. This might be a really interesting way. Of course, we've learned everything we know about heart disease, but we also learned about these precursors and how people's behaviors were related to each other. And so they started a decade-long process where they started mapping the social networks of people, their health behaviors, and how their behaviors were related to their social network, their in-person social network, and how that changed over time. And they found something very interesting. When they looked at happiness, for example, if you're happy, your friends and family have a 15% higher likelihood than chance of being happy. Here's the cool part, though. Their friends and family have a 10% higher likelihood of being happy. And their friends and family had a 6% higher likelihood of being happy. So one person was able to spread this behavior out to 3 degrees of separation. And what the researchers found was that this 3 degrees of social influence is actually a very common occurrence through a number of different types of small, habitual behaviors that we all exhibit as human beings. So what about something like voting behaviors? Why do we still have people going and knocking on doors when we can use social media to spread the word? Is canvassing even effective? So the researchers were hired to use their social networking technology to look at that. And what they found was if you have President Obama here who comes to your door and asks you to go to the poll, that you'll actually be 10% more likely to go to the poll if a human being knocks on your door. But the interesting thing is that even though no one in your house answered the door, they will be 6% more likely to vote, and their friends and family will be 2% more likely to vote. So one door knocker can get approximately 10 to 16 people to the poll for every contact that they have, depending on the average size of the family and the average size of the social network of the family. So that's a pretty important cascading effect. But how does that relate to health behaviors? And these researchers have looked at a number of different things, from sexually transmitted infections to other health behaviors. And it depends a lot on the structure of the network. But one thing that we talk a lot about in the United States, and it's not the best metric, I don't personally think that weight is the best way to measure health. However, it's an easy way. It's an easy metric to look at. The data is easily collectible. So let's look at what they found out when they looked at weight. What they found was that if an individual's spouse gains weight, that individual is 37% more likely to gain weight than according to chance, which seems, intuitive because we kind of, we walk the dog about the same amount as our spouse, we eat the same foods, etc. So there might be some confounding variables there. What happens when we look at siblings? Well, an individual is 40% more likely than chance, even when you control for genetics, to gain weight. And this happens whether or not your sibling lives in LA and you live in New York, or whether you live next door to one another. But let's say that there are some other confounding effects. Maybe you picked up the same types of behaviors and preferences living in your home around eating. But here's the really interesting part. The largest impact was if your mutual friend gains weight, you're 171% more likely to gain weight. And when we say mutual friend, you'll remember the researchers asked people, who are your friends? And if I have 2 friends, Judy and Jane, and I say, Jane is my friend, but Jane doesn't say that I'm her friend, then that's not a tight mutual friendship. But if I name Jane as a friend and she has named me as a friend, that's what's called a mutual friendship in their regard. So a mutual tight friendship has a huge amount of influence on our behaviors. And the influence went down. So this percentage went down the weaker the relationship became between the 2 individuals. So the reason that I point this out is because this research taught us something. And again, there was that same 3 degrees of separation. And this went for smoking, it went for weight gain, and the like. Human beings have an amazing capacity to be social, which we really in the workplace have pathologized in many ways. You know, we want to maintain professional boundaries. We want to eliminate too much emotional TMI in the workforce. However, we have a very, very strong connection mechanism in our brains at our disposal. And I think that most researchers would argue that regardless of what we do in the workplace, many of our behaviors and preferences are driven by the associations that we have outside and within the workplace. And by not facilitating an environment where we connect people and make people feel connected to one another and feel related and see a relevance between their situation and their coworker's situation in life, if we don't foster that, then we are not taking advantage. We're only using our social capabilities as humans to spread bad behaviors, and we're not using those same proclivities to spread the kind of behaviors that could be life-enhancing for those individuals and beneficial to our organization as well. So now, how do we do it? There's a specific process. So at the county, what we used was a process that I had spent the last decade developing. It's a project management approach to cultivating the kind of relational cultural change that is necessary to spread positive health behaviors. The first step of the approach, and we repeat this every year, the first step of the approach is data. We need to gather a lot of data. What kind of data did we gather? We pulled together a summit of our health plans, our short-term and long-term disability plans, our workers' compensation plan, our payroll and benefits representatives. We looked at health risk assessment data for what we had. We looked at survey data from employee surveys about what people had said about wellness. We looked at participation in our current wellness programs. And this first process for us, I've done it in organizations in under 6 weeks, if you have the template of what to look for, but I think most organizations should, the first time that they do this, should expect for it to take anywhere from 3 to 6 months. And I would try to be aggressive in your follow-up with your vendors and aggressive about your expectations. And the first point is to get everybody together in a room, say over what period should we look. And so we're one of those organizations that has some messy things around our data, like our healthcare enrollment period is from January 1 to December 31, but our fiscal year runs from June to July. So, you know, we had to make notes about things like that. We had to all agree with our vendors about how we were going to define our data variables, and then we had to do a huge amount of coordination and follow-up to make sure that we were able to get some of that data. And I don't mean to intimidate you. I don't think it needs to be huge. But when we talk about data and follow-up, after that meeting, we sent a calendar invite to everyone that would recur weekly saying, hey, get us that data you agreed to get us in the meeting. And then occasionally we would follow up. So I don't want to scare people. I think it's important to just collect a little data, though, and to really, again, not play slops with your wellness program, but know where you want to go with it. So what we could clearly see from our data, and I'll show you the data in a minute, was that there were some trends that we needed to address. And so what we did was we took that data and said, here are 6 priorities. And part of this process, the next step in this process that I'm talking to you about is the first step is gathering data, creating a benchmark. But the second step is creating grassroots engagement. And so that first piece addresses in the hero the measurement and analytics piece and the strategy piece. Because once we saw the data, we could pick 3 behaviors that we wanted to influence, or 6 behaviors that we wanted to influence very deeply over a period of 3 years, doing 2 campaigns per year that were really aimed at changing those behaviors specifically. And I'll show you what those behaviors were for us in a minute. But once we'd identified what issues we wanted to tackle, the next step really is that moving from strategy and measurement and analysis to tactical implementation, engagement methods, communication, and program level support. And how did we organize that? Well, the first is what we did by identifying network influencers. So we went to all the county leadership. And in some organizations, this will be easier than the county. The county has 10 departments that oversee everything from elections to chasing down bed bugs, to catching stray dogs, to running the jails, to helping victims of crime, to prosecuting criminals, to finance. So we do it all. We have lawyers, we have jailers, we have doctors and pharmacists. We're the public health arm. So we really do it all. And so we had to go and identify our leaders and talk to our leaders about who is influential in your department, who's positive, who do people have a natural affinity for, who are the people that spread emotional contagion in your department, and bring as many of them to us as possible. We then went through a process. Part of the process that I created has a script where we reach out to supervisors. It has a job description for the wellness team. We share that with supervisors, get their approval to have those influencers serve on a wellness team. And additionally, most organizations can't necessarily afford to have wellness team members out of the workforce for long periods of time for meetings. So we make lots of accommodations. Cheap technology like we're using here for GoToMeeting, you can use that technology to accommodate people conferencing in. You can record meetings and have people listen to meetings after the fact if they weren't able to attend. And we created a job share system where 2 to 3 people in a work group can share the number of meetings for the wellness team so that not all of them have to be there at once. Once we talk to the supervisors, we talk to the individuals about the commitment, and then we sign them up for a series of 8 weekly meetings. Each meeting has a very specific outcome from it. The first is to sort of orient them to this new process of thinking about wellness. The second is to tell them what strategic issue we're going to be tackling. We don't tell them how. In that meeting, we give them the data that I'll be showing you in a minute. We tell them about our key issues and what we're going to be working on for this particular campaign. And each wellness team only serves for 5 to 6 months. We don't have people repeat because we don't want to burn them out. We want them to continue to be enthusiastic, and we don't want our workforce to be able to tune people out. We want it to always be changing and fresh and new. So in the first meeting with the team, we orient them to the process. In the second meeting, we orient them to the issues. We give them the data. We say, here's what researchers, we give them a big list of ideas around how to organize a campaign, and we say, here's what researchers say are the best types of programs to tackle this issue. But now, what do you have to say about this issue? Why do you think your coworkers might or might not participate in one of these research-backed programs? Here are the things that we already offer through wellness that no one uses. Why do you think they don't use it? What could we do to overcome that? And then we really ask that group to brainstorm just a whole host of things, everything from communication tactics, wild ideas, to activities, to resources, anything, incentives, and a number of different very specific themes in campaign organizing. We ask them to come up with everything that they think would overcome the obstacles that their coworkers face. And when we do that, in our 8 meetings, we then walk them through a process where we use 6 key areas of organizing a campaign. That's the campaign theme and branding, that's campaign communication tactics, that's campaign activities or behaviors or challenges, it's campaign resources, and it's incentives. So we have them in each of those categories whittle all of the ideas they came up with down to a few that they think are going to be the most doable and the most impactful in the population. And then we don't let scope creep get in. We then spend the last 4 of our 8 meetings having them break into teams and then create a very detailed tactical plan about how they're going to roll out these activities that they chose. They'll create the things themselves in many cases or use a template from our health plans that they often want to tailor. And the beautiful part of this is that it gives you transparency into your process. You're working on your key issues. You're doing it with these network influencers. And the reason you don't just do it all yourself as a coordinator, maybe I could do a better job, arguably. Who knows? My brochures might look nicer than the team's. But what we really want is their ownership. Because what we know is people aren't reading the emails and they're not looking at the posters. They're listening to their friends. And we've already identified these folks as the kind of person where one contact with this person could influence 20, 30, 50, 100 people in our network. So we feel these people to feel ownership. And part of this process is making sure that our facilitator, and we'll see what kind of key attributes that facilitator needs to have, that our coordinator and our facilitator, when working with the team, is doing everything they can so that these people come out of that 8-week process really feeling ownership and a need to tell everybody and engage everybody in this campaign. It also brings a certain amount of transparency. When we take that strategic plan and we identify our key issues, anyone who works in wellness knows that everybody and their brother has a pet project that they want you to work on. One day, they need you to replace the hygienic wipes in the fitness center. The next day, someone wants you to do a campaign about fragrance-free workplaces. The next day, there's always some pet project. There's always a director. There's always a manager who says, hey, my buddy's company has this and this type of a pedometer or gaming technology. That'd be great if we had unlimited resources. And I will say at the county, we have 2 folks who basically are the equivalent, myself and another individual, who basically are, 0.8. of an FTE. So we really can't effectively run every program and get the kind of results we want. But because we had data, and because we identified our strategic priorities, and because we have the backing of management to run out our process this way and to use this team, we can say to folks when they come to us with our ideas, that's a really great idea, and I wonder if it might fit into one of these upcoming 6 campaigns in some way. And I think it would be great if you could nominate yourself for the wellness team or join the wellness team so that you can advocate for your idea. Because to this team, we really, whenever someone comes to us with an idea, we say, that's a great idea. I mean, if a piece of equipment is broken, we fix it, obviously. But we say, that's a great idea. How will that fit into our campaigns? We'll bring it to the team, and the team will deliberate and discuss. But if you want to be part of that deliberation, please serve on one of our teams. So again, really making it an employee-owned process. And then at the end, we run our campaigns for 5 to 6 months, and we collect the data that we can about them, whatever data we're able. In the beginning, in your first year or two, this will only be participation data. All of those, if someone has diabetes, our campaigns are not going to cure that. It may help them with their adherence if they're at an early stage, but it's going to take a while for our data to start reflecting changes in the population health, but we can look at specific things. If we're doing a campaign around heart health and heart disease, one thing that we'd like to see in our claims is in future years, are people adhering to their hypertension medications and refilling their prescriptions on a more regular basis? Are people getting their blood pressure screened? Do people know their numbers when we do a health risk assessment? When we do a survey and we ask people how much they know about heart disease and the risk factors for a heart attack, can they answer it? So there are lots of different ways for you to get that data. Depending on the size of your organization, you might not have access to all the data that we did, but you have access to some. And you can be smart about thinking about what that data is from the beginning and being really intentional about not just measuring generic HRA data, really asking about the behaviors that you were looking to change. If you wanted people to have increased awareness around heart attack risks, do a survey before and after the campaign asking people about heart attack risks and entice them to somehow take that survey twice and compare notes. Do people's scores improve, et cetera? So that's just one idea for how to use data. And we use that to then look at our strategic plan again and say, are we still on the right track? What did we learn from this? How can we do things better? And to always make every campaign more effective. So again, 2 campaigns a year, 6 strategic issues, and a continuous improvement process where we continually come back and ask if we're working on the right things and if we did the right stuff based on our data. At this point, I want to just check in with folks and see if anyone here has questions. I'm just going to, sorry, you're going to see part of my screen here. Is there anyone who had any questions that you wanted to ask before I move into some of the more sort of specific details around how we organized?
Tanya, hi, this is Alex from IBI. I had a question about, you were touching on this a little bit earlier, but you had a tight budget to work with. Mm-hmm. You're talking about having basically 0.8 of an FTE to work with. What would you say to those who are looking to maximize the budget that they have and the resources that they have?
That's a great question. I think the data is the key there. Collecting the data first and not trying to do everything and not even trying to do a ton is the first piece. You want to focus on doing only what matters. Now that might be hard if you have people who have a lot of conflicting needs and wants, but that data it allows you to say to people who have capricious ideas about what they want you to do for wellness to say, look, this is why I think this is important, and if we can fit your idea into doing this, great. The second thing is, yes, a lot of employers rely very heavily on incentives to get engagement. So I read a Wall Street Journal article recently in March that said that 90% of employers with wellness programs offer incentives and that the average incentive value is now up past $550 per employee per year. Many of those are so high because they're tied to benefits, but that's not an option that the county had, for example. We have 11 collective bargaining units. We can't arbitrarily decide to change our benefit plan design without there being serious bargaining ramifications. And in many of our bargaining units, we, for example, sheriffs and parole officers, we can't have a lack of coverage, so we can't allow people to go on strike. So a judge might determine what we offer. So we don't get to make that designation necessarily. Also, we had only 50 cents per employee per year to spend on incentives. The public doesn't take kindly to hearing that public employees, that $500 a year in taxpayer dollars are being given to employees in the form of incentives. So how did we then get the kind of participation and communication we wanted? Really on relying on those influencers. So many hands makes light work. If you have 120 hours worth of work that you need to do to communicate with everyone in the organization, well, first of all, your FTE might not have that over the period that you need it for the campaign. And second of all, and this is, I think, the more relevant piece, even if they had those hours, they don't have the right relationships. Some people are going to like what you have to say or what your coordinator has to say. Others won't. So instead, by spending the hours that you have coordinating and cultivating this wellness team, and the number that I would use if I were you is 1 wellness team member per 150 employees in your organization. If you're a very small organization, then 10. Use 10 wellness team members because some will drop off, anywhere from 6 to 10. If you're a large organization, think about having a team that has approximately 1 member per 150 employees. If you're a very large organization, you can rotate that through the workplace. You don't need to have 30 team members on your first team. You can just, as you rotate the teams out, you'll eventually get there. And so why does that matter when it comes to money? Because when you think about the resources, when you distribute the work of communication over all of those different team members, now you have 120 hours worth of work, but you have 10 team members, so each person is only doing 12 hours in a 2 or 3 month period as opposed to one person doing 120. Not only have you spread the work, but because people are doing the work, they have ownership, and because you have 12 different people with 12 different human networks, you're spreading the verbiage far and wide. But using this central organizing process, using your hours to facilitate these 8 monthly meetings, and then 8 weekly meetings, and then the 4 monthly meetings to check in on how the campaign is going. Using that planning process means just like a campaign, just like an electoral campaign for a political candidate, we're coming up with our party talking points. We're coming up with our party toolkit. We know what points we want to hit, but then we leave it up to our canvassers to go out into the neighborhoods and get everybody to the polls for us. And then we have them come back, we regroup, we re-strategize, we think about new talking points based on their comments, and then we send them back out into the field. So think about it really like that, and that's a great way to spread the dollars around. Any other questions before I move forward? Just a quick time check. Okay. So this is one of our plans, and it's not exactly apples to apples because when we have a health, an HMO, managed care organization for one of our plans, they don't track, clearly they're not paying claims. So when somebody goes to the doctor, the doctor is hired by the managed care organization, so it's not the same as our insured plan. So for some of these, you're only going to see our self-insured data, and for some that have apples to apples comparisons, to the extent that we can, you'll see our fully insured data. I will say, though, that in looking at certain types of reports, though we can't necessarily do an apples-to-apples comparison, the overall trends are the same. And what you're seeing here in our data baseline is that for 4 years of data, at the county anyway, and it's important to know these kinds of things. If you're an employer that has a very young workforce, you're going to have a different environment than we have. If you have a different type of benefits plan, that creates certain incentives and disincentives, it's going to create different types of behavior. But because our workforce is older, and because it's relatively stable, and because our healthcare coverage is so comprehensive, what we found is that we don't look like, when people talk about the ACA or Obamacare, they're really focused on these Medicare, Medicaid populations and people who rely on, for example, emergency services in order to their medical care. And so you might hear, a lot of people talking about reducing their emergency room or inpatient healthcare costs. But what we saw was that in our nearly $60 million a year medical claims budget, most of our dollars were not being spent on emergency room services, and the ones that were primarily tended to be for the types of illnesses that you would imagine would have that kind of necessity, things like cancers. So when we looked at what we could actually influence, we could see that by and large, most of the dollars on our health plans were being spent through physicians' offices or outpatient treatment facilities, and over half of each of those categories were being spent on surgery. So then we said, well, what kind of surgeries? What we could see is that more or less, musculoskeletal illnesses were by and large driving about $6 million in claims per year. That's not going to be different than most employers, particularly not most employers with an older workforce. But what we needed to say is, hey, we need some ways to, is this just a problem in surgeries? Is everyone getting hip and knee replacements? Are there precursors that we could be impacting, and how? It also helped us prioritize. So we said musculoskeletal issues are our first thing to prioritize, and we need to think about, what does best practices say are the best kind of population health interventions there. Obviously, on the plan design side, we need to look at what kind of surgeries are people getting. Are we providing the right incentives and how we reimburse our plans? And do we need to work with our unions to educate them on why getting a surgery isn't always necessary? Are we offering the best and safest medical care? And is there a way that we could design it so that if people are electing to get surgeries, that at least they're safe? We could also see that cancers were part of the equation, as well as genitourinary, which is, in our case, it's going to be mostly kidney diseases, endocrine diseases, diabetes, and then circulatory, which is going to be mostly heart disease. So you can see that we had three biggies that are preventable: musculoskeletal illnesses, circulatory, and diabetes related. But what we could also see is that we had a huge prevalence of joint disorders: back pain, neck pain, shoulder pain, hip pain, knee pain. It was also a very prevalent condition, which means that there were many, many claims out there that are not at high cost, but could potentially be that because there are many small little seeds of musculoskeletal illnesses out there. So we realized this was really the first thing that we needed to look at. We also looked at our disability claims by long and short-term disability. And again, musculoskeletal illnesses topped the charts, tumors such as cancers, and then circulatory issues around, again, looking at things like heart disease. So gosh, that seems like a lot, and I've talked to you guys about using these teams. I'm sure that when I talk about this, there is maybe a little bit of fear that people feel when they hear about having to organize a team over 8 weeks, and oh my gosh, it would just be easier to do it all myself than to corral these cats. But I will say that the outcome is much better if we can create a focus in our organizations around community and around, again, using those human mirror neurons and the power of making connections, helping people make connections in our workplace, and then using those connections to influence their behavior for the better. So I'm going to give you some keys to how you can organize that wellness team, some things to think about when you're organizing that wellness team that are going to make this more effective for you and more rewarding. It's as much of an art as a science, but we have done, so this is data from Recess. Because obviously the county is just one sample, so it's not going to be, you're going to want a bigger swath of data. But county data is in here as well. And over all the employer wellness teams, every single one after every campaign receives a survey with the same questions that asks them what they liked and disliked about serving on the wellness team and what the process was like for them. So again, this is because you have your influencers, you're herding these cats, you're wanting them to work on an issue that you've deemed strategic, you've given them information on what best practices say, and you need them now to stay engaged and feel ownership so that they'll spread the word and they'll take to the streets for your candidate, which might be reducing blood pressure, or in the case of Multnomah County, we worked on trying to get people to sit less. So our first campaign was really emphasizing small motions that got people to sit less based on our data. Our next campaign on cardiac health. So how are we going to make this topic, which quite frankly could be quite boring if we wanted it to, relevant to a diverse enough, and you need a diverse team too. They can't just be the health nuts that everybody says, well, easy for you, you're skinny. You need the people who are interested and positive, but might not necessarily be the most obvious wellness champions. Maybe they care about it, but you don't necessarily want a bunch of unrelatable skinny minis. This team needs to be ethnically diverse, from an age perspective diverse, socioeconomically diverse. And the cool thing about it is the differences at first can be like, whoa, how are we ever going to come to consensus with such a diverse group? But the positive side of that is that teams, by and large, say that their number one motivator for participating in this team was a novel way to engage with their coworkers. And even if you facilitate these teams via webinar, allowing enough time in the meetings for people to introduce one another, get to know each other's personalities a little bit, if you notice that people aren't volunteering information, to call on them, and to create a set of norms that gives people a safe place to really share their personalities without it being talked about outside of the room. So that's very important. Another very surprising thing is that, most of us who work in benefits, wellness, safety, risk, we're so used to our world, and we know our programs backward and forward, and we know the landscape out there. But it can be kind of amazing to think that other people whose jobs revolve around doing other things 8 to 10 hours a day might not be intimately familiar with the programs that we talk about so much. So going in and first things first, when you're orienting the team, giving them a little bit of homework to dig around what your short and long-term disability carriers offer, what your health plan offers, what coaching programs, what wellness stuff you have in the first place, and then also to look at other best practices programs for other employers. Almost everybody says that they really enjoy learning about those things because they just never realized that their company already offered so much. So this becomes another effective way. Even if those benefits aren't used in this campaign, you now have a super user group that goes out and advocates in favor of those benefits, which saves you a lot of time and work. They also liked the collaborative and social aspect of the work, so it gave them an opportunity once a day to get a break and to work. They often worked on things, but they might be doing design, and their normal job is an administrative assistant, or they might be doing call downs and writing a script or making a video when normally they work with disabled kids or adults. So it's an opportunity for them to collaborate with people in new ways and test out new skills. So those are important things to think about when you're creating the environment for the team. Now, when you create an environment for the team this way, the team then goes out and communicates to their coworkers. And this is how we get, our campaigns. So these coworkers are the face of the campaign. And again, they're taking the talking points that you guys have given them in that 8-week campaign planning process, and they're the feet on the street who are bringing those talking points to the voters. So then, again, this is recess data because the county is such a small sample set, but this is among all employers over the past 10 years through recess. I want to say there are a couple thousand folks in the survey. And again, this survey goes out to all participants at the end of every campaign. And when we ask participants in campaigns that are run this way, why did you or did you not, why didn't you or why did you participate in the last wellness campaign? What we found was, and I do need to change up these numbers because this is no longer the leader anymore, but it used to be that incentives, foods, and prizes were the leader. But again, keep in mind that none of the workplaces in this sample had cash incentives that had a value of more than $50 per year. Every employer wellness campaign in this survey, the cash value of the incentives that they offered was less than $50 per employee per year, and in many cases much less. So at the county it was 50 cents per employee per year for the campaign data that's in here. The second most motivating thing, and this is where your team comes in, and this is now the first when we look at our overall survey scores, is personal relevance. So the personal relevance, and this is what your team members are bringing. They're looking at the person that they're talking to. They're remembering their talking points, but they're going, gosh, I know that Jane really loves her son, and I know our talking points are really talking about, heart health is good for you. But I think when I talk about it, I'm also going to tell Jane, hey, Jane, don't you really want to be here for your son and have your son see you healthy? And studies have shown that, parents who are really engaged in their own health, that's the biggest predictor of their child's health in the next 15 years. So again, these wellness teams use their connections, and they take the talking points, but they increase that personal relevance score and the sustainability of your program because they tailor that information on the fly to their audience. It's not just being broadcast to everyone the same way in an email or a flyer. And additionally, the third highest motivator for campaign participants out of all of the ones offered, and I think there are 15 different choices that they have, ranging from food and prizes to tracking their participation, which never is in the top three. The top three, wellness team communications. So people enjoy the variety of hearing about this from a number of wellness team members and the communication tactics that the team comes up with, which again they brainstorm and are usually more creative than just a flyer. One thing that I think is really important to note is always last in this survey is management communications. I think it's important that management show their support by encouraging the wellness team to be able to attend these meetings and participate in a meaningful way by offering money and support for the program and its ongoing implementation, and by not derailing the program strategy with an initiative du jour. I think those are important ways that management can support and show leadership. However, they're not moving participants toward, they have to be there, but you don't need to trot out management at every event. It's great if they can be a part of it, and they should be part of communicating it, but that's not necessarily what's getting people to the polls. So I think that's a really important thing to point out, is that the management needs to support your grassroots teams. They need to support your efforts at collecting data, at having the time necessary to get the word out, and they need to keep it, financially solvent and not interrupt your strategy unless they have good reason or data. But other than that, you really don't, you're not going to get a lot of bang for your buck in terms of marketing by send out everything. Maybe the first email for the campaign, maybe one or two, but that visibility needs to be tempered with other sources of communication. So when we think about personal relevance, again, it's important here that your role becomes less, I do everything, and everybody on the wellness team knows that they never need to carry out an action item because you or your wellness coordinator or your company is always going to do all of the work. Again, it's fine to do all of the work in one sense. You might be able to do it better, if a series of judges were to judge how beautiful your flyer was. However, what we're going for is relevance and ownership, if you recall. And so the important part is that your team has the relevance to everyone else in the organization, but how do you stay relevant to the team? Because, in most cases, these folks don't directly report to you. They don't directly report to your supervisor, and you have no authority or control over what they do or how they spend their time. So how do you get them coming to the meetings every time, and how do you keep them engaged? Well, again, this is recess data. When we polled our team members, what they said is, and again, we needed to do that to get bigger numbers, but the county is included here. Coordinators followed through with their commitments made to the team. They're dependable. They record and follow up on action items made in the meeting, and they follow up between the meetings. They try to distribute work. So if they notice that 2 or 3 people are dominating, they ask quieter members to share their opinion before they move on with a decision. And that's a very important piece, because if you don't do that, those quiet people don't have the ownership, and they will quietly begin to disengage and not show up in more ways than one. The coordinator had a consistent facilitation and meeting management style. You set an agenda and an objective for every meeting, and you have clear outcomes that you attempt to meet. Provided creative tactics, again, showing the team what best practices say and nudging them if they get stuck. And then everyone understood the coordinator, so having clear expectations. And so those are some of the things that are going to be key to you guys really driving that culture of health in your organization. Before I close, I just want to say people matter to people. And here's a quick little, one of the really fun communication tactics we have at the county. This is a candy bowl amnesty program that tries to let people know usually the person with the candy bowl isn't the one, who's sad about the candy bowl being there, but there are a lot of people at the county who are trying to reduce their weight, and so we're saying, hey, we're all connected. Let's build our connections to each other and eliminate obstacles for our coworkers who are trying to lose weight. Pour your candy into an envelope, send it to wellness. We'll dispose of the candy and send you a fruit bowl, and if you put fruit in your bowl and send us a picture, we'll give you $10 in farmers market tokens to refill it. So again, it's just one example of what that fun, engaging process of working with teams and creating connections between people can produce. There are another couple campaigns. This is our musculoskeletal campaign. I didn't give myself enough time to talk about it, but I wanted to just show the variety of communication tactics that we used, the variety of activities, and I'll make these slides available to IBI. We did everything. We tried everything, and not all of the activities that the team created worked, but some worked very well. So we did something called the 50 Moves Challenge to get people not sitting in their seats. And over a period of and we communicated about it in a lot of different ways. 1 in 3 county employees participated. They logged an average of 30 moves over an 8-week period. In our whole intranet site, we'd only ever had 67,000 submissions to the forms in a 2-year period, 43,000 of which came from this campaign. So again, when you look at the fact that we only had 50 cents worth of incentives, we were able to do a lot and we were able to do a lot more than what is average because of the connections, the communication tactics, the variety. You can see, too, that a lot of the stuff that we focus on are small keystone habits that people can easily change, and all with a lot of novel and surprising ideas from the grassroots, and we really promoted the ones that we thought would work. As we started inspiring people, people started doing those small doable things. It started catching their attention, and change started to take place. So that this individual, for example, started just shrugging her shoulders, then started taking the stairs, then started walking 3 miles, 30 pounds later has lost a lot of weight. And our investment going forward is really to try not to invest in programs necessarily unless we need them, not to invest in equipment, not to really our one-size-fits-one, but to start investing our infrastructure in creating teams, in creating champions, in maximizing engagement and human connection with as little of our dollar resources as possible. So lots of novel ways that we've done that. We've created a mapping project where people can connect with one another. Our IT program did a very grassroots thing using GIS and Google Forms to try to link people all over the county who work together. And if they want to go take a walk with somebody, or they want to swap recipes with someone, or try to lose weight with someone, we're connecting people all throughout, not even using fancy social networking, just using a Google Form and connecting people together. As a result, structurally, our programs have netted a huge increase in our score on the HERO. We're not yet to the trend bending, but we're well on our way. Where we were able to get those gains are through improving our engagement methods, using this team, improving those a lot, increasing our leadership support in ways that mattered, again, supporting our strategic plan, our tactical plan, supporting our teams, and then by driving more innovative programs. And through that, that's where we got most of our improvement. So I hope that that's at least gives you guys some things to think about in terms of where to get started. I appreciate all of your time today, and I'm happy to stay on the line for another 5 to 10 minutes if people are able to go over in order to answer any more questions that you might have.
I might be interested in a short conversation here.
I think somebody may have a question, but you're coming in really softly.
You're welcome to use the chat function too. If folks are still on the line, I'm happy to take a question over chat in your GoToMeeting console.
Ever since I got used to doing the stand-up thing, sitting feels so weird to me.
I do feel like I hear someone talking, but we can't hear what you're saying. How about this, folks? I'm really happy to answer any questions over email after this call. I really appreciate your time today. And why don't, if anyone has a question, make sure to just send your emails to IBI, and I'm more than happy to respond with an answer or to point you to some resources that we used in the design of our program. Thank you guys again so much for having me, and to IBI for hosting this webinar. Keep doing good work out there. Hope to talk to you soon.
Thanks, Tanya, and thanks everybody for making the time.
All right, bye now.
All right, bye.